Hello all, this is discussion on obstructive lung diseases. In obstructive lung diseases, basically taking in air will be easy. That is, your inspiration will be normal. However, giving out air will be difficult. That is, your expiration will start getting difficult. So inspiration is normal, but expiration is difficult. Because of which, the air starts getting accumulated inside the lung. This is what is the basic thing happening in your obstructive lung diseases. So let's see what are the pathological aspects in this. So as far as your obstructive lung disease is concerned, in which you have increase in resistance to airflow, that's what is said. So your FEV1 by FVC ratio is what differentiate whether it's obstructive lung disease or a restrictive lung disease. In obstructive lung disease, the air getting inside starts accumulating, but it's not coming out. So what happens? Automatically your FEV1 will start reducing because it is the amount of air which is exhaled in 1 second. So your FV1 is getting reduced, but your FVC will remain normal. Because of which the ratio is getting below the normal range. The normal range is around 0.8. So it is less than the normal range. Now, speaking on your restrictive part, in restrictive, normally what happens, it restricts the inflow of air. So your inspiration itself is a difficult one. So what happens when you look into your FEV1 by FVC ratio, FEV1 as such is reduced. But when you look at your FVC also, the amount of air getting inside is itself low. So your FEV1 which is coming out is also low, but FVC, which is the amount of air inside the lung, is also low. So since the numerator and denominator is both are getting reduced, you will have a normal ratio. Okay. Getting back to the topic, so obstructive. So obstructive, it basically in which all diseases you can see obstructive pattern of pulmonary function test will be your emphysema, chronic bronchitis, asthma and bronchiectasis. In this, COPD, that is chronic obstructive pulmonary disorder, includes emphysema and chronic bronchitis, and some medicine books also includes small airway diseases. Okay, now on emphysema. So what is emphysema? The definition goes, irreversible enlargement of airspace distal to the terminal bronchiole with destruction of walls. So this is what it says. So distal to the terminal bronchiole, that is your asinus. What is asinus? It basically includes your respiratory bronchiole, alveolar duct and alveoli. So this asinus undergoes an irreversible enlargement. Why the airspace become enlargement? Because the walls are getting damaged. So since the walls are getting damaged, the space becomes so enlarged, it becomes like a loose container. That's what is happening. The recoil nature of the walls are reduced. So this is about your emphysema definition. Now on the types, you have centriassinar, panassinar, distal assinar and irregular. So centriassinar, all these types are based on the part of the asinus which is affected. In centriassinar, it is the proximal portion of the asinus, that is your respiratory bronchiole is affected. In panassinar, pan means entire, so your complete asinus is affected. Distal assinar is the distal portion of your asinus is affected, and then irregular, basically a irregular portion, you cannot generalize histologically which portion is affected, a irregular pattern is seen. So these are the types. So speaking about the centriassinar and panassinar comparing, actually speaking, pathologically irregular assinar will be the most common, but in medicine books say centriassinar is actually the common ones. So centriassinar as such, where you have a proximal parts of your asinine are affected. It is seen mostly in smokers. Whereas in a panassinar, the entire asinus is affected. It is seen in alpha-1 antitrypsin deficiency. Centriassinar will be seen in the apical segments of the lung, whereas panassinar will be seen at the base. These are the differentiating points between these two. And then your distal acinar, one clinching point about it, it has a more increased tendency to go for spontaneous rupture. So it can go for spontaneous pneumothorax. Then coming on to pathogenesis. So as the definition goes, it is an irreversible enlargement of the air spaces. So for irreversible enlargement of the air spaces, all we need is the wall destruction. So our ultimate aim is to have the wall destruction. So how the wall gets destructed? Basically, you have two things. One is your inflammation part, other one is your protease antiprotease imbalance. So in the inflammation, basically what are the factors which can lead on to your emphysema? The main ones are your smoking and then your air pollutants. All these, what happens once these pollutants get inside, it causes inflammation. It causes release of the inflammatory mediators. So all this will lead on to your inflammation. It can even lead on to your chronic inflammations. Along with this, it can even lead on to increase in your free radicals. So oxidative stress develop, which can also, both this inflammation and oxidative stress, both can lead on to your alveolar wall destruction. This is one. Other one, when you look into your alpha-1 antitrypsin deficiency, where you have a genetic disorder, in this basically, this alpha-1 antitrypsin enzyme is an antiprotease. Normally what happens, these antiproteases keep the activity of the proteases in balance. So there is always a balance between the activity of proteases and antiproteases. When you have an alpha-1 antitrypsin deficiency, the antiproteases activity reduces. So the protease activity starts increasing, which leads on to destruction of your alveolar wall. So this is what basically happens. This alveolar wall will lead on to an irreversible enlargement of your air spaces, which will lead on to the subsequent symptoms. Okay. So now, this as said before, there is loss of elastic tissue in the walls. So alveolar wall destructs. So the elastic nature, the recoil nature of the alveolar wall gets affected, because of which you will have an irreversible enlargement of the air space. Air starts getting trapped. This is what the sequence goes. So you can see the inflammatory infiltrates will be seen in the bronchial walls. One thing. And second thing, goblet cell hyperplasia, mucus plugging. Okay, what is the mechanism behind this is actually, you have a normal mechanism working in your body, which is a protective mechanism, that is your mucociliary clearance. What is basically, whenever you have an irritant or whenever you have any dust, any smoke, any air pollutants enters into your body, what happens, your goblet cells start producing mucus. So this mucus gets mixed with these dust, and what you call the so-called sputum is thrown out by the mucociliary action of your airways. So these dust particles are thrown out. So it is a normal protective in nature. Here, the inflammation which is caused is due to all your smoke and air pollutants, etc. So they will start triggering all these goblet cells to produce more mucus. So there will be goblet cell hyperplasia. It's actually an exaggeration of your normal phenomenon. So the goblet cell hyperplasias, which will lead on to your mucus plugging. And then it was also said there is thickening of your bronchial wall due to smooth muscle hypertrophy and peribronchial fibrosis. However, this is more predominantly seen in asthma. Okay, so we have seen now what about the pathogenesis, how it happens. So looking into your morphology. Okay, grossly, when you look at the lung, how it will appear. As I said before, the air starts trapping inside the lung. So the lung starts becoming a voluminous. So it will appear as a large lung, an inflated lung. And you can also see a blebs or bullae will be seen. As you can see, these are the bullae. These are nothing but your air trapped small sac-like. So these bullae, when it ruptures, it can lead on to your pneumothorax. So this is how morphology when you look at the lung. Microscopically, when you look at it, what we can see, inflammation is there, So you can see your inflammatory cells can be seen, inflammatory exudates can be seen. Then along with it, sputum can also be seen because you have a goblet cell hyperplasia, mucus production will be there. And then your goblet cells will be hyperplaced. And then the most important thing comes. Thin, abnormally large alveoli separated by a thin septa. What is this? This is what the definition says. You will have your enlarged, dilated airways. Because of the destruction of the wall, what happens? Your alveoli and starts becoming like a large, loose containers, and then the septas are also becoming thin, and then decrease in capillary bed area. Because of the large alveoli, what happens? The area for perfusion is getting decreased. That is, your capillary bed area starts decreasing. So these are the three things you can see microscopically. Then looking into the clinical features. So as said before, you will have dyspnea because of difficulty in exhaling out air, and also you will start feeling breathlessness. So you will have dyspnea, you will have wheeze, cough with sputum, weight loss, barrel chested. Why it appears barrel chested? The inflated lung, the enlarged lung will give the appearance of the chest as a barrel. Along with that, you will also have a flat diaphragm. Also, the patient sits in the hunched over position because he feels more comfortable in such position, and pink puffer. Okay. Next is your chronic bronchitis, which is also part of your COPD. So the definition of chronic bronchitis is persistent cough with sputum production for at least 3 months in at least 2 consecutive years. So it is a clinical definition. Persistent cough with sputum production for at least 3 months in at least 2 consecutive years. It is also same common in smokers and also people living in metropolitan cities where the pollution is more. So smoke-laden cities. And a differentiating point is your emphysema will never lead on to a col pulmonale, that is your right heart side failure, whereas your chronic bronchitis have an increased tendency to develop your cor pulmonale and right heart failure. Okay. Now looking onto the pathogenesis of chronic bronchitis. Here also you have two things. One is inflammation and next one is your mucus hypersecretion. So these two are the ones leading on to all your clinical symptoms. So why inflammation? As I told before, you have the causative etiology is tobacco smoke, dust from grain, cotton, etc. All this, once on prolonged exposure to all this, it can lead on to inflammation. Along with the inflammation, as I said, the mucociliary clearance mechanism, which is a normal protective reaction. What happens? It starts exaggerated. So you will have your mucor hypersecretion due to the hypertrophy of your mucus gland and also your mucous gland and also your submucosal glands. So the goblet cell hyperplasia occurs. Now, once your mucus hypersecretion occurs, what happens? It will lead on to your secondary infections. All these mucus is a fertile ground for the infections to develop. So these infections will keep on having your inflammation and everything, and it maintains your chronic bronchitis. So this is what the pathogenesis. Exposure to an etiological factor, tobacco smoke or whatever, that leads on to your inflammation and as well as your mucus hypersecretion. So morphology. So morphology, grossly when you look, you will have the signs of your inflammation. So hyperemia, swelling, edema, etc. And then excessive mucus secretion. So this excessive mucus secretion is also. Now you have something called bronchiolitis obliterans. That is obliteration of your lumen by mucus plugging and fibrosis. That is, in your airway, the mucus starts plugging, and that along with that, it also the inflammation leads on to your fibrosis. So what happens? This both starts blocking or obliterating your bronchioles. So this is called as a bronchiolitis obliterans, obliteration of your lumen. Microscopically, when you look, one thing, you can see all the signs, all your inflammatory cells, inflammatory exudates, all can be seen. And next thing what we have stressed on is your hyperplasia of mucus gland. Now, how is your hyperplasia of mucus gland is calculated. We have something very important called as your RAID index. So what does the RAID index is that the thickness of mucus gland layer to the thickness of wall between epithelium and the cartilage. This gives you a RAID index. Normally it is 0.4. That is thickness of your mucus gland layer to the thickness between the epithelium and the cartilage. The ratio is normally 0.4. But in your chronic bronchitis, it will be increased. It will be much more increased because your numerator is getting increased. That is the thickness of your mucus gland layer. You will have the hyperplasia so getting increased. So RAID index. Next, clinical features. So here, as the definition itself says, you will have a persistent cough with copious sputum. Where the difference we will see later with the emphysema. And then you will have dyspnea late, and it's also called as your blue blotters. Now, the differentiation factors between your emphysema and bronchitis. So, bronchitis will have an earlier onset, that is around 40 to 45 years, whereas your emphysema will have a later, that is 50 to 75 years. And then clinical symptoms, as I have said before, dyspnea will be predominant in emphysema, whereas in chronic bronchitis, it will be appearing late and it will be mild. But when you look at your cough, in chronic bronchitis, cough will be the first and the common symptom, whereas in emphysema, cough will appear late. And in emphysema, the cough will be of scanty sputum, but as in chronic bronchitis, it will be of copious sputum. So this is what. And then because of your sputum, you will have your secondary infections as well. That is one thing in your chronic bronchitis. And cor pulmonale, as I already said, is more in case of chronic bronchitis. Next is your appearance, that is blue blotter and pink puffer. Why chronic bronchitis is called as blue blotter and emphysema is called as pink puffer? See, in emphysema, we have dyspnea as the main symptom. Since the patient is having dyspnea, he will start attempting to take voluntary breaths. That is, he will start going into taking a deeper breaths. So, since he is having difficulty in expiration, he will start giving a forced expiration. Because of which, since he is going for a voluntary actions, so he will start pushing out more carbon dioxide outside. So there won't be any accumulation of carbon dioxide because the patient will start forcing out air. So the patient will appear as a pink puffer where he will have hypoxia but his carbon dioxide will be pushed out. So he will have a pink puffer appearance. Whereas in case of a chronic bronchitis, the patient is having a symptom only of cough, but he doesn't have much dyspnea. So the patient never attempts to take a voluntary breaths. That is, he never attempts to go for a voluntarily breathing out air. So in chronic bronchitis, the carbon dioxide starts accumulating in the lungs. It will lead on to your cyanosis. Also, so the patient accumulation of your carbon dioxide, your cyanosis, all this appearance will give a blue blotter appearance in chronic bronchitis. Okay. Next, getting on to the other obstructive diseases. So bronchiectasis is one in which when we do a PFT, it will have a obstructive pattern. So, as such, what is bronchiectasis? It is also again said that bronchiectasis is actually irreversible dilatation of your bronchi. This is what your definition says. But before that, you need to understand one thing in the bronchiectasis is this vicious cycle. So in the cycle, at any entry point if you enter in, it will lead on to your bronchiectasis. That is what the pathogenesis of bronchiectasis says. Inflammation will lead on to bronchial obstruction. Bronchial obstruction will lead on to your pooling of secretion. Pooling of secretion will lead on to a secondary infection, which will again lead on to inflammation. So this is how the cycle goes. Let's go by step by step. Bronchial obstruction. So whenever any obstruction, it can be a foreign body aspiration, foreign body obstruction, or whenever a tumor growth which is obstructing the airways, or even in your TB, you will have your lymph node obstruction. So when you have after a TB, when the lymph node gets enlarged, that is also obstructing. This is called Brock syndrome. So in all these cases, foreign body, tumor, lymph node enlargement, all this, when it causes your bronchial obstruction, so the obstruction will lead on to your pooling of secretions, which will lead on to secondary infection and inflammations. So when you enter a bronchial obstruction. Now, let's look into the pooling of secretions. So when you have pooling of secretion, in which all conditions you will have pooling of secretions? When you have primary ciliary dyskinesia, that is a Cartingner syndrome. In Cartingner syndrome, what happens? There is a defective cilia. The cilia is defective due to defect in your Dynein nerve. So when your Dynein nerve is affected, you have a defective cilia. So when cilia is defected, what happens? Your mucociliary clearance is also affected. So when mucociliary clearance is affected, automatically your pooling of secretions occur. So in primary ciliary dyskinesia, you will have pooling of secretion. And the another condition is your cystic fibrosis. So what is this cystic fibrosis? In this, you will have it's a genetic disorder in which the mucus produced will be thick in nature. It is due to CFTR gene mutation, so because of which you will have a defective chloride ion channel. So because of this, the sputum or the mucus what is produced will have a thickened consistency nature. Because of its thickened consistency, it is difficult to get it cleared off. So it will also start pooling of secretions. So these are the ways. So when pooling of secretion occurs, automatically it will lead on to secondary infection. Secondary infection will lead on to your inflammation. This is. And then secondary infections. So whenever it happens, for instance, whenever you have a post-infective stage, for instance, in child, the measles and pertussis will lead on to your bronchiectasis, and adults the TB. So all these things will again lead on to your inflammation and bronchial obstruction and pooling of secretions. So in child, measles and pertussis, and in adults you will have TB. So these are the things which will lead on to inflammation. And other triggerers, there are multiple things which can have inflammation, which can also lead on to your bronchial obstructions. So this vicious cycle keeps on going, which will lead on to your bronchiectasis. So what does the bronchiectasis? Because of the keep on inflammation, what you ultimately end at? You will end at irreversible dilatation of your bronchi. And that irreversible dilatation is also very abnormal. So it is actually abnormal irreversible dilatation of bronchi. It will be dilated sometimes even up to 4 times the normal range. So this is what you basically see. So as I already told you, primary ciliary dyskinesia, it's autosomal recessive disorder where you will have defect in your Dynein nerve, so retention of secretion. So what is your Cartingner syndrome? So Cartingner syndrome has 4 things within it. One is your bronchiec. All this Cartingner syndrome is due to a cilia defect. Because of the cilia defect, you will have bronchiectasis, you will have male infertility, you will have chronic sinusitis and situs inversus. So this X-ray shows where you can see the situs inversus. So this is what is your Cartingner syndrome. Next, cystic fibrosis, as already told, there is a defective mucociliary action due to thick viscous secretions. And then next is your ABPA, that is allergic bronchopulmonary aspergillosis. In this also what happens is it is an hypersensitive reaction to your Aspergillus fumigatus fungi. So what happens, hypersensitive reaction? You will have the inflammation. So you are entering at the inflammation part. So the vicious cycle starts going. So it will lead on to your bronchiectasis. So we have seen on the pathogenesis. Now getting into the morphology. So morphology, grossly when you look, it's basically affects the lower lobes, and most importantly it affects the distal bronchi and bronchioles. That is what the thing is. Bronchiectasis mainly affects the distal bronchi and the bronchioles. So the definition itself says it is the abnormal irreversible dilatation of your bronchioles. So you will have the bronchi and the bronchioles dilated. On cross section, when you see, the dilated bronchi will appear cystic and then they are filled with your mucopurulent secretions. Here the sputum will be of mucopurulent in nature because of the secondary infections. Now, so going into the histology. Histology, as you know, inflammation, so inflammatory exudation will be there. So the chronic inflammation, what will happen? It will lead on to the necrosis. So the necrosis will lead on to the destroy of your bronchial walls. So chronic inflammation leads on to the necrosis, and the necrosis will ultimately lead on to your fibrosis. So necrosis of the bronchial walls occur, and which also lead on to your fibrosis. And then one thing which is given in Robbins is the squamous metaplasia. In bronchiectasis, the normal epithelium is actually a pseudostratified ciliated columnar epithelium. This is what in your up to your respiratory bronchial, this is what your epithelium is. In case of your bronchiectasis, you will start having a squamous epithelium. It's a pre-malignant conditions. So you will have squamous metaplasia. And then as I already told, secondary infections are very common. Sputum will be mucopurulent. You will have staphylococci, pneumococci, or Haemophilus influenzae, Pseudomonas aeruginosa, and even fungal hyphae in case of your ABPA can also be seen histologically. So morphology, all you can see is the dilatation. Basically dilatation on cross section you can see the cystic changes with mucopurulent nature. Histologically, inflammations can be seen due to inflammation, necrosis and fibrosis can occur. And another important thing is the squamous metaplasia. Next, so clinical features. Because of you have your excess sputum, so you will have severe persistent cough, and the expectoration is of foul smelling. Other than that, you can have dyspnea, orthopnea. An important one is here you can have hemoptysis. So normally in your COPD, hemoptysis generally won't be there. But in case of your bronchiectasis, there will be a hemoptysis. Okay. So this is what about your bronchiectasis. Next is about your asthma. So asthma is also one of the disorder which have an obstructive pattern. So it's a chronic disorder of the conducting airways due to increased airway sensitivity to variety of stimuli, which is all mediated by an immunological reaction. That is what the definition is. So to a stimuli, there is an increased airway sensitivity. This increased airway sensitivity is due to immunological reaction, because of which you have a conducting airway disorder. So what is actually happening in your conducting airways? The key thing is your bronchoconstriction. So you will have an episodic bronchoconstriction. Along with it, you will have increased mucus secretion as well. So the bronchosecretion along with your increased mucus secretion will happen. Okay. So now looking onto the classification of asthma. So there are certain classification of asthma, that is your atopic asthma, non-atopic asthma, then you have your drug-induced asthma, all this. So this is one way of thinking. And your atopic asthma is also called as your extrinsic asthma. Okay, so it's extrinsic asthma, and so this atopic asthma is the most common type. It is also called as your extrinsic asthma. It is usually seen in your childhood. So basically this atopic asthmas will be more common in child, and once they reach their adult ages also, it will start reducing in its incidence. Whereas your non-atopic asthma will be seen in adults, and it is actually a kind of a more severe thing which does not get subsidized as the days goes. Whereas in atopic asthma, once the child attains adulthood, the incidence starts, the episode starts decreasing. So it is a IgE mediated type 1 hypersensitivity reaction. So type 1 hypersensitivity reaction. So what all are the triggerers? It is basically all your environmental allergens, the most basic common your household allergens. That is your dust, pollens, animal danders, food. All these things are your basic triggerers, because of which the patient develops hypersensitivity. So just brushing up your type 1 hypersensitivity. First phase is the sensitization to your allergen. So once the allergen comes, it will be presented by the antigen presenting cell to the Th2 cells, that is the T helper cells. So this T helper cells will start producing interleukin 4, which will stimulate the production of IgE by the B cells. So the B cells will start producing IgE due to the action of interleukin 4. This IgE will start binding to the mast cells in the IgE-Fc receptor, and then it will produce your interleukin 5. What is this interleukin 5? Interleukin 5 has the action of recruiting eosinophils. So the eosinophils recruitment occurs, and then once the eosinophil recruitment occurs, it starts a degranulation, and the degranulation leads on to your early phase of your type 1 hypersensitivity. So this is how it happens. So first thing, initially there will be a sensitization. Then on the next exposure to the allergen, the type 1 early phase starts occurring. So once the type 1 phase occurs, what happens? You will basically have all your early mediators released from the eosinophils, from the mast cells, and even directly from the nerve endings. You will be having certain mediators released. So what are those? The base and mediators are your leukotrienes C4, D4 and E4, and then your acetylcholine and your histamine, prostaglandin D2 and platelet activating factors. So these are the things which comes from your eosinophils, mast cells. Apart from that, you will have your eosinophil cationic protein and major basic proteins. So okay, once these mediators comes, what are the actions of these mediators? As you know, the leukotrienes C4, D4, E4 and your acetylcholine, your histamines are all bronchoconstrictors. So once these mediators are released, it will cause your episodic bronchoconstriction. So the episodic bronchoconstriction will occur. Along with this, your platelet aggregating factor will cause a clot, and then prostaglandin D2. This prostaglandin D2, along with bronchoconstriction, it will also cause vasodilation. So you have increased vascular permeability. So this is also one of them. So this is what happens in your early phase, that is your immediate hypersensitivity. You will have your bronchoconstriction, you will have increased mucus production. Then after a few hours, what happens? All the inflammatory mediators which was chemotaxed to the spot will start producing its inflammatory mediators. So all these inflammatory mediators will be responsible for your late phase. So all in the late phase also, you will have all the inflammatory processes going on. So this is what about your atopic asthma and its pathogenesis. It's nothing, it's actually a type 1 hypersensitivity. Next is your non-atopic asthma. So in non-atopic asthma, the thing is there is no evidence of allergen sensitization. So here the hypersensitivity reaction does not take place. So skin tests are usually negative. So what all are the triggerers are your respiratory infection, that is your rhinoviruses, respiratory syncytial viruses. So all these viruses can be a triggerers for asthma. Your smoking, sulfur dioxide, nitrogen dioxide, exercise and cold. So these are the two even physiological factors which can even become a triggerer for asthma, your exercise and cold. Next is your drug-induced asthma. This is not a common one, it's very uncommon. But how it happens is basically aspirin and other NSAIDs. These are the common etiology for your drug-induced asthma. So basically what happens, all your aspirin and other NSAIDs, that is your COX inhibitors, they inhibit the cyclooxygenase pathway. So there is a decrease in prostaglandin E2 production. But at the same time, all your arachidonic acids and all will be channelized for your lipooxygenase pathway. And also it is said The prostaglandin E2 is always having a check on your lipooxygenase pathway. So lipooxygenase pathway is getting increased. So you will have an increased production of your leukotrienes B4, C4, D4 and E4. So all this will have a action of bronchoconstriction. So this is what happens. This is the pathogenesis, what is happening in your drug-induced asthma. Cyclooxygenase pathway is suppressed and your lipooxygenase pathway is exaggerated or increased. Lipooxygenase pathway is positively regulated. Okay. So next is your occupational asthma. That is your fumes, the organic and chemical dusts, gases, formaldehyde, penicillin products, all can cause occupational asthma. Even a small amount of these things can cause, even when on exposure to all these things, all these fumes and organic chemical dusts, in a small quantity itself can lead on to asthma, and it can be, what is the pathogenesis? Either it can cause a hypersensitivity reaction, all these things can cause hypersensitivity reaction, or in certain cases these things itself directly can cause release of your mediators. So these mediators can lead on to your bronchoconstriction. So when we look into all the classification of asthma and the triggerers, we looked into something which we see each and every day, especially in case of your atopic asthma. All those things are household allergens which we see each and every day, but everyone doesn't develop the so-called asthma, but some do develop. So what is a possible reason is, one is the genetic. Certain people are more prone for getting asthma, that is, who have a polymorphism of interleukin 13, class 2 HLA alleles and polymorphism of ADAM33. So people who have all these genetic factors will have an increased more prone for having asthma. And then the most important, another one is your hygiene hypothesis. So what does your hygiene hypothesis says is, basically, okay, simply it means hygiene hypothesis, when at the younger age, when you are exposed to all these allergens and everything at the younger age, the chance of you getting asthma is less. Compared to a child who was not exposed to all these allergens at a younger age, he has an increased chance of getting asthma. So this is what your hygiene hypothesis says. So what is the reason behind this is that at birth, you will have more of Th2 helper cells. So Th2 cells will be more. On exposure to all these antigens, what happens? All these Th2 cells will get converted into Th1 cells, which will lead on to reduced amount of asthma, that is reduced incidence of asthma. But in child who is not exposed to all these allergens, this Th2 cells will remain as Th2 cells, which will lead on to cause asthma. So this is what the basis of hygiene hypothesis. Next is on your morphology. So morphology, as we have seen, one is your bronchoconstriction and another one is your increased mucus production. So you will have a thick mucus plug formation will be occurring. There will be a thick mucus plug. Now when you take this mucus and examine it, you can see 3 C's. So these are the 3 C of asthma: Churchman spirals, charcot-laden crystals and Crayola bodies. So what does this 3 C's says is, Churchman spirals are nothing but when you take the sputum and stain it, you can see the mucus plugs in the form of this spiral. So this pattern is the Churchman spiral. And then next is your charcot-laden crystals. So these needle-like crystals are nothing but your galactin 10 protein starts accumulating. And this accumulation will appear in the form of a needle-shaped crystals. These are called as the charcot-laden crystals. And this galactin 10 comes from your eosinophil. Next is your Crayola bodies. What is this Crayola bodies is basically the lining of the epithelial lining of the respiratory tract will be slowed off. So your ciliated columnar cells which got slowed off will get accumulated, and that accumulation, that when you see, that is called as your Crayola bodies. So the 3 C's of asthma: Churchman spirals, charcoal-laden crystals, and Crayola bodies. Next, the most thing in pathology of asthma is the airway remodeling. So when you have asthma, when you have the multiple episodes of asthma, when you have asthma on a long duration for a chronic manner, you will have a airway remodeling. So what is this airway remodeling? Let's go from, so normally what the airway remodeling comes to say is, you will have a thickening of the airway wall. So thickening of the airway wall, that's what is happening. So let's go by the layer by layer. First you have your epithelium, then submucosa, then you have your bronchial wall muscles, and then the cartilage also. So this is how the layer goes. Now in the epithelium and in the submucosa, the epithelium, the goblet cells, and in the submucosa, the submucosal glands will start hyperplasia, which will lead on to increased mucus production. And then in your basement, below your submucosa, the basement membrane what you have, there you will have your fibrosis. So sub-basement membrane fibrosis will occur. Then when you come to your muscle layer and even the cartilage in your trachea and the early bronchi, what happens? You will have the hypertrophy as well as the hyperplasia of the bronchial wall muscle. So in each layers of your, in each histological layers of your wall, airway wall, you are having hypertrophy. So the overall the thickening of airway wall occurs. And the next one is your increased vascularity. It's a very important one. Here in asthma, you will have angiogenesis. New vessels will start forming. So here there you will have an increased vascularity. In case of your COPD, where especially emphysema, where we said the capillary bed area decreases, here the vascularity increases. So there the perfusion will be decreasing, here the perfusion will be increasing. So you will have the perfusion increase in asthma is actually due to your angiogenesis. So this is your normal airway, and then this is your airway in asthma, where you can see the thick mucus, and then the goblet cells also getting hyperplasia. And comparing to the normal airway, you can see the basement membrane due to fibrosis is also thickened. There is deposition of type 1 and type 3 collagen. And then your submucosal glands are also getting hypertrophied. Then look at your smooth muscles. Comparing to normal airway, here there is the hyperplasia as well as the hypertrophy of your smooth muscle layers. The cartilage layer will also have a hyperplasia. So overall there is a thickening of your airway wall. This is called as airway remodeling. So what all are the clinical features in your asthma? As you all know, you will have the class wheeze, you will have dyspnea, chest tightness, cough, and they all usually occur in the night and the early morning. Usually during this time only the asthma generally happens. So and as far as diagnosis is concerned, you can go for clinical symptoms, difficulty with expiration, clinical symptoms, and then when you look at when you take the sputum, when you look at the sputum, you can see eosinophils and the 3 C's: Churchman spirals, charcoal-laden crystal, Crayola bodies. This is about the sputum examination. And then in the blood, you can see eosinophilia in case of atopic asthma. In atopic asthma, you will have blood eosinophilia, and when you do RAST also, you can find the specific antibodies to the allergen. So to the specific allergen, you will have the specific antibodies which can be determined by your RAST also. So these all are seen in your atopic asthma. So that's about your obstructive lung diseases. Thank you.